You want to start now? Oh yeah, wait, later, okay.
Can you see my slide?
Can you see my slide?
Hello?
Yes, yes.
Okay. So for today case presentations, me Murashazoni Bati Zulkifli. So I would like to start our case presentation. Okay, this is my patient biodata. Okay, so proceed to the chief complaint. So my patient Ravdatu Sakina, a 3-year-old, 11-month old Malay girl with underlying congenital heart disease was admitted to pediatric ward HDA with complaint of fever for 1 month. So she was apparently well until 1 month ago when she suddenly developed fever. Her mother noticed the fever as it was warm upon touch. The fever was intermittent in nature without chills and rigor. There was no documented temperature at home. However, the fever was temporarily relieved with syrup paracetamol. And also, she became less active and lying on the bed due to the fever, and she also having reduced in appetite. The mother did not notice any weight loss, and there is no lesion noted at any part of the body. Okay, for other symptoms, she had cough, which was non-productive in nature, and also she also had runny nose, which there was a clear discharge. Okay, however, there is no arthralgia and no abdominal movement, no night sweat, no headache, no history of traveling, water activity. There is no abdominal pain, vomiting, or diarrhea, no yellowish discolorations of the eye or joint pain, and there is no seizure, no hematuria, smelly urine, and increase in urine frequency, no red eye, and also no rash. So, due to fever, she was brought to the clinic by mother, and the documented temperature was 39.5 degrees Celsius, which was high grade fever at that time. And she was given antibiotic and antibiotics. And mother claimed that she finished course of antibiotic for 7 days, but daughter become easily tired when walking few steps, and she's still not active. And then upon further questioning, she had history of heart surgery at 10 months old and had repair, and also she had multiple dental procedures, which was tooth extraction, and an incidental finding during appointment at cardiology clinic HTA. Echocardiogram was done and revealed there was vegetation found at the aortic valve, and thus she was admitted to ward for further management. And then proceed to the past medical history. So she had multiple previous hospitalization before. The first hospitalization when she was 10 months old at National Heart Institute, and she was diagnosed with aortic stenosis and having birth defect which called bicuspid aortic valve. And she had undergone operation which is percutaneous transluminal balloon aortic valvoplasty, but currently having problem with that. And she is planned for another heart operations due to leaking at the aortic valve, and however, it was postponed due to dental issues. And also, apart from that, she had multiple dental visits due to dental caries and tooth extraction, but mother not remember whether she was given antibiotic prophylaxis before the dental procedures. Otherwise, there is no other chronic illness or any surgical procedures. There's no drug and food allergy in these patients, and there is no history of taking any other supplement. So regarding the immunization history, so she was immunized complete up to age, and no complication of immunization such as fever or rashes happen. And then for birth history, um, mother had gestational diabetes mellitus on diet control and hypertension without requiring medication, and mother was told that she was small for gestational age. However, there is no infection such as herpes simplex and HIV. And for intrapartum, she was born via spontaneous vaginal delivery at 35 weeks with birth weight of 1.8 kg. And postnatally, She had neonatal jaundice and low birth weight, and where she needs special care for 1 month. Otherwise, no history of intubation. So for growth and development, according to the mother, she is small for her age, and the developmental milestone for this patient is also normal corresponding to her age. Okay, for nutritional history, she is not exclusively breastfeeding up until 6 months. And then after that, mother mix formula milk and also breast milk. Okay, for family history, she is first out of two siblings. Otherwise, there are no family history of bronchial asthma, malignancy, diabetes mellitus, hypertension, autoimmune, and heart disease in the family. So patient lived at Cendrawasih, Kuantan. It was 10 minutes drive to HTA. There is total of 4 people living in the house, and mother works at a company, and father works as a freelance trainer, and household income around 5,000 per month. And otherwise, there's no people smoking in the house and not involved in any high risk behavior such as drug abuse and sexual promiscuity. Okay, proceed to the physical examinations. Okay, so the patient was conscious and alert at that time, and she was sitting comfortably on the bed. She was not in pain and not in respiratory distress. There were no desmospheric features, but she looks small for her age and also looks pale. However, there is no finger clubbing, no stigmata of infective endocarditis such as ocular node and generations, and she is not sinus. On oral examinations, uh, there's a presence of dental caries. However, the lips were not dry, and the oropharynx was not inflamed, and tonsil were not enlarged. Okay, for the anthropometric measurements, so her weight is 11.9 kg. So I have plot on the growth chart, and and the weight is below the fifth centile. So this patient having a failure to thrive. Okay, so for vital signs, so all are good. Okay, with normal tensive and heart rate, normal heart rate, normal respiratory rate, and not and febrile. For cardiovascular, so uh, okay, and my examination focused on cardiovascular examination, and on palpation, the apex beat was palpable at fifth intercostal space anterior axillary line, no trills and parasternal heave. On auscultation, murmurs heard at aortic and mitral area, but loudest at the aortic, which was ejection systolic murmur, loudest on expiration with grade 3 out of 6. Okay, for abdominal examination, the abdomen soft and non-tender, no hepatomegaly and splenomegaly or any ascites. On respiratory examination, there is no pleural effusions. Other systems were unremarkable. Okay, so for summary of the cases, Raulata Sakina, a 3-year-old 11 months Malay girl with underlying congenital heart disease, which is aortic stenosis, diagnosed since age 10 months old, repaired but leaking, currently presented with prolonged fever, also as having loss of appetite and less active. This is her first hospitalization due to fever. And on physical examination, review cardiomegaly and also ejection systolic murmur on expiration, heard at aortic mitral area at aortic and mitral area, which loudest at aortic area. So my provisional diagnosis could be infective endocarditis. Okay. Continue, doctor.
Yeah, continue. And do you
Okay.
have any question to ask now?
Yeah.
Any question to
Anyone
ask?
having question to ask?
Yes, no. Feeling, angguk.
Okay.
If don't have, then just off it on your mic and say don't have lah. Don't have. Sambung je. Sambung. Second ni tak?
That, that, that's
Tak ada
okay.
soalan, sambung. Sambung. Continue.
Okay, continue, doctor. Sorry.
Tak dengar apa?
Tak dengar, doctor. Itu Ferdinand ni, doctor. Sorry.
Microphone.
Okay. So for why infective endocarditis, for points 4 is patient having unexplained prolonged fever. loss of appetite, and also she had underlying congenital heart disease, previous valvuloplasty procedure, previous dental procedure, and also have been cardiac murmur. Points against that this patient have no stigmata of infective endocarditis. So for my other differential diagnosis, the first one is rheumatic valvular heart disease secondary to acute rheumatic fever. However, this patient do not feel Jones criteria, and also okay. And for the second one is pyrexia of unknown origin because she had fever without other symptoms, and points again is presence of heart murmur with underlying congenital heart disease. And the third one is urinary tract infection, um, having a prolonged fever and intermittent, but deny any lower urinary tract infection symptoms. And the last one, which I can give is Kawasaki disease because the fever may progress prolong also at least 5 days and above. However, does not having the fulfill the criteria also. There is no rash.
Yeah, but in Kawasaki, the fevers are likely to last for about a month. Okay, usually it
Oh,
burns itself out after by about 2 weeks because your history was a month intermittent, isn't it?
yes.
Right? Usually Kawasaki will burn itself out after roughly about 2 weeks or so. And usually the fevers won't be intermittent, it'll be like very, very high for the first week or so, and then slowly it will taper off.
Okay.
Jadi sambung. Okay.
Proceed, doctor.
So what investigations would you do?
Okay, investigation. The first one is full blood count. So the full blood count in this patient reveal hypochromic microcytic anemia with white blood cell count high, which was 14, and also the ESR and also CRP also high, and the blood culture and sensitivity reveal gram-positive streptococci. And for echocardiography, so there is a vegetation seen at aortic valve, and also there is a moderate mitral regurgitation.
Okay, so Shazwani, so basically, if you do an FBC, what are you looking for if you're taking into account your provisional and your differential diagnosis? I know that's your results, but what would you look for?
The the white cell count
Okay, what would you expect?
high.
Yeah, it might be high, it might be normal, like, depending on how severe the infection, how recent the streptococcal infection is, isn't it? All right. Okay,
Yeah.
what else would you look for?
The hemoglobin level
Okay.
and also maybe
What were your differentials again?
in fact differential acute rheumatic fever,
Mm-hmm.
urinary tract infection,
Uh-huh.
pyrexia of unknown origin, and also Kawasaki disease.
Okay, so based on your differentials, what would you look for?
In full blood count,
Yeah.
uh, the platelet level, I would see the platelet level also because in Kawasaki disease, it may have thrombocytosis.
Uh-huh.
Mm.
I just hate. I just hate what. Okay, say hello everybody. Thank you, bye bye. What will you come up with? I don't want to watch uh, heaven video about monster. Then don't watch monster mallet. Listen, these are all mommy students, okay? Okay. These are all gonna be doctors in like a few years time. Okay. Okay. Say hello. Hello. The day your sister crashed the class, today your turn to crash the class, is it? No. No, not today. Turn to class. You see so many girls, how many boys in it? One boy. So boys are not better than girls, right? Okay. Yeah, I do you. Okay, Sarvani, sorry. Okay, Sarvani, continue. So you expect the thrombocytosis, what's platelets behind? Oh, sorry.
Leukocytosis.
Will make, oh, will make. Sarvani, sambung je. Okay. Okay, sambung je.
Renal profile and also liver function test also was done in this patient. However, all parameters were normal.
Okay, now if you think if it now if you think infective endocarditis is the provisional diagnosis, so what's your complications of infective endocarditis that you think that?
So patient can have heart failure
Okay,
and also maybe sepsis.
okay. Now it's not only just the heart, isn't it? Infective endocarditis can be a multi-system thing, right? So you get embolic phenomenon.
Oh,
Basically,
embolism.
you the what's that thing called? The emboli from the heart valve can just disperse everywhere, isn't it? Right. So if it disperses into your brain, that's why sometimes we can prevent it. Hematopoiesis can get seizures, right? If it disperses into your kidneys, then they can also prevent it.
Glomerulitis.
Hematuria, renal dysfunction, renal impairment also, right? So that is one of the reasons why we need to look at renal profile also, right? All right, Mark. All right. Continue.
Also, based on modified criteria, patient had definite infective IE by fulfilling two major criteria in clinical criteria.
So your choices of your investigations is not only just to uh, decide on the diagnosis, but it's also to look for evidence of complications, right? So that's why you need to do a liver function, you need to do a renal function. Because renal function might be compromised. When you do a physical examination, things like splenomegaly, hepatomegaly, those are things you should look out for, and then when you present, you see whether they are present or they are not present.
Hmm.
Sambung? Okay.
So for management of this patient in ward, so this patient may get intravenous penicillin C and also IV gentamicin
Mm-hmm.
in the ward, and the blood pressure was monitored for hourly and being watched out for failure symptoms, and she was advised to continue current feeding, and she was planned for throat swab, maybe to exclude any streptococcal infection, suspected acute rheumatic fever.
The blood culture was already positive, right?
Yes,
Blood culture was already positive, right?
the blood culture and sensitivity only.
I know the blood culture, gram positive streptococci, right?
Yes,
It was already positive, right?
yes.
Now the blood culture you have to do sequentially because you have to document that the uh, streptococcus has been eliminated. But if your blood culture is already positive for streptococcus, do you think a throat swab is needed? But obviously you do a throat swab on admission, isn't it? Right now. To show evidence of streptococcal infection, right?
Yes.
You would do it together with your blood culture lah. But anyway, your blood culture is already positive. So if your throat swab is negative, it doesn't really mean a thing at all lah, right?
Mm. Yes. Betul. Okay, and then she was given IV furosemide.
Okay.
And that's all for my case presentation.
So, okay, what do you guys want to talk about? You guys have any questions for your Shavani now?
I have a question.
Good question.
Uh, she was given furosemide. Does it indicate that she is already failing, or is it some prophylaxis?
Mm, I think because the early signs of failure symptom which the patient having cardiomegaly. So but I'm not sure is it having prophylaxis for heart failure or not. Sorry, doctor.
You don't give prophylaxis for heart failure, but the fact that the child already has, am I talking? The fact that the child already has cardiomegaly already shows it's already a sign of heart failure, isn't it? I'm sure during echocardiogram they will also assess the child in clinically also assess, so that's why they probably give furosemide. Now you don't give furosemide just for the sake of giving, you give something for a reason, isn't it? Right? Osler notes, Janeway lesions, you guys know how they look like or not?
Pardon, doctor.
Osler notes and Janeway lesions, you guys know how they look like or not? Huh? Do you know what they look like?
Yes.
Yeah. Yeah.
Doctor, I have a question.
Uh,
Why because based on the PITS protocol, if the infective meningitis, the management could be the patient will be given penicillin G, but this patient was given penicillin C. Is there any differences?
what is penicillin G and what penicillin C? Because it's not penicillin C, it's IVC penicillin.
Oh, IVs.
The way they're right. It's the way it's written. Penicillin G,
Oh,
because it's benzoyl right? But when it's written in the IV form, it's IVC penicillin.
IV. Oh, okay, okay.
Yeah. Because it's there. Now when you write it in your prescription, when you write IV, it's C penicillin. That's the way it's written. Benzyl penicillin is penicillin G. That is the name. You get it now? It's the same thing. It's just that the way you write. It's kind of like saying it's saying writing RM3 and 3 ringgit Malaysia. You get what I mean? Faham tak?
Yes, doctor, understand.
Any other questions? Oh, no, February not presenting. Okay, let's see. Let's see.
Doctor,
Yes.
to ask, is there when do we use failure to track or smaller age, smaller for age?
Definition of failure to try. What's the definition of failure to try? You can be small for age, but you may or may not have failure to try. When you're small for age, you're small for age lah. Basically, you're below the fifth or third centile lah, isn't it? Failure of try, one of the definitions is when you cross the centiles, right? So you can have failure to try, but still be within the centiles. So if this is your, yeah. Okay, the girl is going to come and photobomb now. Yes. Yes, I'm having a customer. Okay, so let's just say this is your growth chart, right? Okay, this is your growth chart, right? I see now. The two centers of your growth chart. If you are small for gestational age, it's basically just looking at the fifth centile. So anything lower than that, you're small for age. Not gestational age, depending. You're talking about kids, so sometimes you say it's small for age, right? Now, if you cross two centile lines, then it's failure to thrive, right? So if the first time you see the child, you think the child is here, then you immediately say, no, you don't have a reference range for his centiles, right? Then most likely there's also failure to thrive, got it? But let's just say you've been following up the patient, and the child started down here, and is now catching up. You would say that child is having catch-up growth, not so much failure to thrive anymore. Got it? If we saw the child here, maybe not 90th lah, maybe 50th centile, right? As we follow the child up during follow-up for whatever reason lah, he crosses two centiles, but he's still above the fifth centile. That's still considered failure to thrive because he crosses the centile. That's why I say you can have failure to thrive, but you may not necessarily be below the fifth centile, right? But you may not have failure to thrive even though you're small, right? But basically, if you're small for age, just basically means that you're below that last line, right? And then a failure to thrive is crossing the centile, right? Any other questions?
Okay.
Good question or not? Now I compiled a few I compiled a few YouTube videos about CVS. What time is it? 2:30. So, by the way, Oscar's note and Greenway regions look like that. Oh, So osseous nodes and genuine lesions would look like that, right? Tell me whether you're seeing the video or not, okay?
Can see, doctor.
Can see? Okay. Now I will send RD. Yeah, do you? Yeah, I'll send Adila the message with the YouTube links lah. So easier you can watch in your own sweet time. But
Okay, doctor.
then there's a few there's one on cardiac murmurs and one on examination technique, which is quite simple and easy to understand. And then this one, let me see. Now, this one would
Cardiac
easy
history
to
today
understand.
about the cardiac history and physical exam when evaluating children for possible cardiac disease. Our objectives to
Okay, so this is for cardiac examination. It's quite okay. And then this one will be about, this one has a few, my Wi-Fi is a bit unstable, so it's a bit susah.
يبقى ده عرضة أي حاجة هتودي.
Okay. And then there'll be a few videos. I can't play that one. I don't know why. There'll be a few videos on
Hi, this is Tom from ZeroToFinals.com. In this video I'm going to be going through heart murmur, second heart sound, systolic contract sound. So let's have a listen to that now.
So those videos when I think the cardiac murmur one, you listen by yourself on your phone and with earphones, because if I play it here, I doubt you'll be able to hear the murmurs very well. Do you want to look at the examination technique together, or you want to just do it in your own seat time because you're early? You need 2:30. No answer. Yes answer.
Together.
Yeah, look together. You want to do the CBS one?
Together.
Because after this you probably be watching some other immediate videos instead. Okay. Give me a second.
Right, so this is, I'm going to demonstrate how to do cardiovascular examination in a child, and over the years that I'm doing this, certain things people fail to do. For example, we had a teaching session involving some undergraduates where 9 out of 10 missed an extracardia. It's quite shocking, but that's what actually happened. And I think one of the things is they didn't feel the apex with both hands to check that the apex was in the correct place. So that's an example of something that sometimes goes wrong. It's very important when examining children that you make them at ease, and of course that's harder when you're in an exam setting, but I think it's generally a good plan. I've seen on a number of occasions in my career people ignore elevated blood pressure, so I'm not going to check this child's blood pressure today, but this isn't, unfortunately, such a rare occasion. And obviously if a child's got an elevated blood pressure in a ward setting or in the outpatients, that needs to be addressed in some way. So that's just a note about that. In terms of the cardiovascular examination, I'm now going to do that with this nice young lady here. Oh, hi, so what's your name then?
Molly.
Okay, well, nice to meet you, Molly. So I want to find out whether you've got a healthy heart or not. What do hearts do for you?
They pump blood around your body.
Gosh, I thought they just made you come. Oh, right. Okay, so first of all, I'd like to have a look at your fingers, and I want you to do something for me, which is a little bit funny. And you do that like that.
That's like sign language B.
Yes, but just one finger on each side, so I can just look between them. So imagine I was looking through like that. Yeah, that's fantastic. Yeah, obviously checking for clubbing here. And can I have a look at your hands and just look at your hands in general? Oh, what have you got all over your hands?
Pen.
Right, okay. So I want to do something now which is called checking your pulse, which is essentially feeling how fast your heart is going. I'm going to measure it with a watch in a moment. Okay, let me see how fast your heart is going. Is it going bum-diddy-bum-diddy-bum-bum, for example? Probably not. Okay, so normally in a thorough cardiovascular examination you should measure the pulse for a minute. I'm going to do it for 30 seconds just to save a bit of time. You're letting me do that very nicely, Molly. Okay. And you're assessing the usual characteristics of the pulse, rate, volume. And I'm also going to check pulses in your ankles, because guess what, your blood pumps all the way down there. And I'm going to check your pulses at the top of your legs. Yeah, it's a bit ticklish, isn't it? Let me just check. Okay, and that's nice and strong. And also, because you're a big girl, let me just sit you up for a moment and just check the pulse in your neck, because I don't think you've ever felt that you have a bit of a thing there with your blood going up to your head. Otherwise your head would drop off, wouldn't it?
I feel it when I'm running.
Yes, indeed. Can you lie back down again there? That's fantastic. So having done all that, doing all the peripheral pulses, I'm now going to assess the apex and check that it's in the correct place. And as I said, the best way to establish where the precordium is most prominent is to put your hand on both sides of the chest, and then I now found the location for the apex, and I'm going to make sure there is midline trachea, sorry about that, and make sure there's no evidence of mediastinal shift. And then I'm going to press a little bit hard here, and that's to find out if there is a heave on this side or on that side. Thank you very much. And then I'm going to check to find out whether or not there is any kind of thrill going up into the upper mediastinum, into the notch here, and there isn't anything of that nature. So the next thing I'm going to do is have a listen and see if you're a kind girl or not. And I want to remind paediatricians that if this child's entirely appropriate dressed for age for this examination, but I always warm my stethoscope before examining any child for any purpose which involves a stethoscope. I'm just going to first of all listen to see if you've got a kind heart or not. And I'm going to listen to your heart in different places. Okay, I'm also going to listen over your neck. What I'd like you to do for me, I'm going to sit down. And I want you to take a really deep breath in. So watch me, I'll show you how to do it. Yeah? Good girl. That's well done, Molly. And then all the way out. And when it's out, just hold it there just for a second. Okay, you did that very well. You must be practicing. And then I'd like you to do that again, but I'm going to listen at your back.
Okay.
So, in and out. All right, thank you very much, and lie down for me. And I just want to check that your liver is not swollen at all, because that's something that happens when people have right-sided heart failure. Indeed, it's the first sign of heart failure in young children. And your heart is working perfectly well. And I also want to check that you haven't got any edema. Funny word, isn't it, edema? I've been practicing that for years. Yeah. And you've not got edema. Thank you very much for that.
Doctor, you're muted.
You're muted, Doctor.
Okay, hi. I had to mute it because somebody busybody again just now. Okay. So that was the basic examination technique. It's the same as an adult law when you're that age, isn't it? Right? What thing is, you guys always forget about the auscultating the back and feeling for the enlarged liver. Also, the apex beat thing is important lah. Like you said, a lot of people will miss out a textual cardia. So always remember to feel. If you cannot feel on the left, always remember to feel on the right. Don't go and make up signs and say you felt the pressure on the left, but actually couldn't feel anything. Right? The other clue will be when you auscultate at time the heart sound sounds very soft, then perhaps you should auscultate the right side and see whether it's louder on the right side. Almost 1 hour. Hey, you wanna watch one more? There are examination. The one that I sent to Adila just now was this one, and then there's the one about general examination. Then there's one about auscultation. So that's the one where you can hear all the murmurs. And then another two are examples of examination techniques lah. Okay. So wait, these two are a younger kid and an older one. What? I don't use this. No, what is it? Yeah. By the way, he thinks I'm joking when I say I have a class. I'm not joking, am I? You are not joking. But Yeah, school start next week. So okay. Okay, so I think you guys just just get the message, the link from Adila, and then just watch it on your own, lah. Okay.
Doctor,
Yeah.
I have question.
Mm.
For the Osler note and generalization, apart from for diagnosis, can it indicate the severity of the IE or chronicity?
No, it doesn't indicate severity or chronicity. No, it's just a sign. You see.
So the severity of IE is just we monitor the severity of the infection itself, lah, the sepsis.
It's not the infection itself because it depends on how much. It depends on the vegetation, and it depends on how severe it has disseminated. Right? So if you got a vegetation in the heart, and then you give antibiotics, but it doesn't clear off, the infection doesn't clear off, it keeps on disseminating to your kidneys, it keeps on disseminating to the brain, it keeps on it causes pulmonary embolism. So that would become more severe, lah, right? I had a 10-year-old kid who died before because of this. Was in the ward for like ages, given high dose of antibiotics, but it just disseminated everywhere. And so he ended up dying in the end. Somebody wants to join the group. Okay, it's clinical. Basically it's clinical lah, isn't it? And also whether your penicillin manages to eradicate the infection or not, manages to diminish the vegetation, right? Any other questions?
Doctor, I have question.
Yeah.
Before blood stain came out, so we give the patient empirical antibiotic. For the duration of total duration of antibiotic is usually 4 to 6 weeks, right?
Sorry. Can you say again?
For the duration of antibiotic in IE, is it included if we give the empirical, is the empirical antibiotic too that we include in the 4 to 6 week duration?
Yeah, if your antibiotics is the correct antibiotics, yes, 4 to 6 weeks. But then also you have to make sure that your blood cultures are negative at least twice, isn't it? Right? The subsequent follow-up blood culture. No, presence of Janeway lesions or osseous nodes do not indicate severity.
Doctor, I have question. How can we say that the patient has free from infective endocarditis?
Echo, mission no vegetation, right? That's why you have the echo. Your blood cultures must be negative. At least 2, I think, if I'm not mistaken.
So after 6 weeks, then we do echo and blood CNS again.
Yeah, but your blood CNS you're doing sequentially anyway. Okay, Nana has $3. Okay, if both of you are going to disturb me, both of you are going to do development. You are going to be specimens for development data assessment maybe. What? Okay, Nana has $3. She used 27 cents. Oh wait. Okay, guys. On an ice cream. On a cheap ice cream. Enough for the. One is better at math than the other. Okay, so any other questions? Any other questions?
No, doctor.
Doctor. You get these two folders for developmental assessment and social. Okay. Okay. Tak dengar cakap. Okay, bye-bye.
Thank you, doctor.
You just give your friends lah. Okay?
Thank you, doctor.
Okay, doctor. Yeah, bye-bye.
Thank you, doctor.
Okay.
Bye, doctor.
Okay.